Let me tell you about something I see repeatedly in the emergency department that on the surface makes very little sense. A patient comes in, usually somewhere in their 50s or 60s, complaining of crushing fatigue, aching muscles, low mood, and a vague sense that something has been wrong for a long time. They look exhausted in a way that a good night's sleep does not fix. Their GP has run blood tests, everything has come back normal. They have been told they are fine, and yet there they are in front of me, clearly not fine. What is striking about these patients is not the severity of their symptoms, it is how long they have been living with them. Months, in some cases years, of assuming that this is just what getting older feels like, that the fatigue is stress, that the muscle aches are from not exercising enough, that the brain fog is just life, and in many of these cases, when we run a more detailed panel, we find the same thing, a deficiency so common in the adult population over 50 that some researchers have described it as a quiet epidemic and so routinely missed by standard blood testing, that the majority of people who have it never receive a diagnosis. That deficiency is vitamin D. And the reason it keeps getting missed is not that doctors do not know about it. It is that the way we test for it, interpret it, and act on it has been fundamentally inadequate for decades. Vitamin D is not a vitamin in the conventional sense. It is a steroid hormone precursor that regulates the expression of over 200 genes throughout the body. It governs calcium absorption, immune system calibration, muscle function, cardiovascular health, insulin sensitivity, and neurological signaling. When it is deficient, genuinely deficient, not just at the low end of a reference range that was set without adequate regard for optimal function, the consequences reach into virtually every organ system. And yet, in the standard annual blood test, it is frequently not measured at all. When it is measured, the threshold used to define deficiency is so low that a substantial portion of functionally deficient people are told their levels are acceptable. By the end of this video, you will understand exactly what vitamin D does in the body, why the standard testing and reference ranges are poorly suited to identifying the people who most need attention, what the real consequences of chronic insufficiency look like across a lifetime, and what actually corrects it. This is not a story about taking a supplement. It is a story about a hormone system that modern life has systematically dismantled, and what that costs. Credential introduction. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years on the front line in the AAND, I have seen what happens when chronic deficiency goes unaddressed for long enough. I have seen osteoporotic fractures in patients who had no idea their bone density had been silently declining for a decade. I have seen patients with severe myopathy, muscle weakness so pronounced they struggle to stand from a chair, whose vitamin D levels had been flagged as low but never adequately treated. And I have seen the exhaustion and low mood that accompany long-standing insufficiency misattributed to depression, overwork, or the inevitable effects of aging. My goal is to help people understand what is actually happening in their bodies so they can ask the right questions and get the right answers before the consequences become serious. If you are watching this video, you are probably someone who has been told at some point that a blood result was borderline, or that your symptoms do not quite explain themselves, or that you should perhaps take a general multivitamin and see how you feel. And I want to make you a promise. I will keep creating the most evidence-based, practically useful videos I can grounded in real science and real clinical experience to help you understand your own health at a level that actually empowers you to act on it. All I ask in return is that you give this channel a fair chance and hit the subscribe button. If you get to the end of this video and you have not learned something genuinely useful, feel free to unsubscribe. No hard feelings. But if you give me your time and attention, I will give you everything I have learned from more than a decade in medicine. Please hit the subscribe button and help this channel reach more people who need this information. And let us get into it. To understand why vitamin D deficiency has such far-reaching consequences, we first need to correct a fundamental misunderstanding about what vitamin D actually is. Despite the name, it is not a vitamin in the usual sense. True vitamins are organic compounds that the body cannot synthesize in adequate quantities and must therefore obtain from food. Vitamin D is different. The body manufactures it, or is designed to manufacture it, through a process that begins in the skin when ultraviolet B radiation from sunlight converts a cholesterol derivative into a precursor molecule called cholecalciferol. That precursor is then converted by the liver into a storage form called calcidiol, and finally converted by the kidneys and various tissues into the biologically active hormone calcitriol. The reason this distinction matters is that vitamin D behaves like a hormone, not a nutrient. Calcitriol, the active form, binds to vitamin D receptors that are present in virtually every tissue in the human body: the intestines, the bones, the muscles, the heart, the pancreas, the immune cells, the brain, the skin. When calcitriol binds to these receptors, it regulates gene expression, it switches genes on and off. Research published in the journal Genome Research has identified over 2,000 genes that carry vitamin D response elements in their regulatory regions. That means vitamin D has the capacity to influence more than 10% of the human genome. No other single nutrient or hormone precursor comes close to that breadth of biological reach. Vitamin D is not a supplement you take to strengthen your bones. It is a master regulatory hormone that governs the operating conditions of almost every system in your body. The key functions are worth understanding in some detail because they explain why deficiency produces such a diffuse and seemingly unrelated cluster of symptoms. The first and most well-known function is calcium and phosphate regulation. Vitamin D is essential for the intestinal absorption of dietary calcium. Without adequate vitamin D, the gut absorbs only 10 to 15% of dietary calcium, compared to 30 to 40% in a vitamin D sufficient state. When calcium absorption falls, the body maintains blood calcium by drawing it out of bone, a process mediated by parathyroid hormone that, if sustained over years, progressively undermines bone density and sets the foundation for osteoporosis. The second function is skeletal muscle regulation. Vitamin D receptors are present throughout muscle tissue, and calcitriol directly influences muscle fiber composition, contraction speed, and the rate at which muscle recovers after exertion. Research published in the Journal of Clinical Endocrinology and Metabolism has demonstrated that vitamin D deficiency is independently associated with reduced muscle strength, impaired balance, and a significantly elevated risk of falls in adults over 60. This is not a subtle or marginal effect. In one study population, adults with severely deficient vitamin D levels had a fall risk more than twice that of those with optimal levels, even after controlling for age, physical activity, and baseline fitness. The third function is immune system modulation. Vitamin D receptors are present on virtually all immune cells: T cells, B cells, macrophages, dendritic cells, and calcitriol plays a critical role in calibrating the immune response. It enhances what is called innate immunity, the rapid first-line defense against pathogens, while simultaneously suppressing the excessive inflammatory responses that drive autoimmune conditions. Research published in Nature Immunology has shown that T cells cannot even activate properly without adequate vitamin D. They require vitamin D to trigger the signaling cascade that initiates an immune response. This is the mechanism by which vitamin D deficiency impairs the body's ability to fight respiratory infections, and it is the same mechanism by which it has been associated in multiple large population studies with elevated risk of autoimmune disease, including multiple sclerosis, rheumatoid arthritis, and inflammatory bowel disease. The immune system does not just benefit from vitamin D. In a fundamental sense, it depends on it to function at all. The fourth function is cardiovascular regulation. Vitamin D influences the renin-angiotensin system, the same hormonal network that governs blood pressure, and has direct effects on the smooth muscle cells lining blood vessel walls. Research published in Circulation has associated vitamin D deficiency with elevated blood pressure, impaired endothelial function, and an increased risk of both heart attack and stroke, independent of traditional cardiovascular risk factors. The proposed mechanism involves vitamin D's role in suppressing renin production. When vitamin D is deficient, renin rises, angiotensin II increases, and vascular resistance climbs. It is a pathway that connects a hormone most people associate exclusively with bone health to the same circulatory mechanics that drive hypertension. The fifth function is metabolic and neurological. Vitamin D receptors in the pancreatic beta cells that produce insulin are essential for normal insulin secretion and insulin sensitivity. Multiple studies have shown that vitamin D deficiency is independently associated with impaired glucose tolerance and an elevated risk of type 2 diabetes. And in the brain, vitamin D receptors are present throughout the cerebral cortex, hippocampus, and cerebellum. Calcitriol influences the synthesis of serotonin and dopamine, the neurotransmitters most closely linked to mood regulation, and research published in neuroscience and biobehavioral reviews has shown robust associations between vitamin D deficiency and both depression and cognitive decline in older adults. Just a quick note, if you are finding this useful so far, please do consider subscribing to the channel. It genuinely helps these videos reach more people who need this information. Now let us continue. Naming the systemic failure. So let me name this specific problem directly, because it is one that sits at the intersection of how blood tests are ordered, how reference ranges are set, and how modern life has fundamentally altered the biological system that was designed to produce vitamin D in the first place. The standard blood test used to assess vitamin D status measures the storage form 25-hydroxyvitamin D, or calcidiol, in nanomoles per litre. The reference range used by most UK laboratories defines deficiency as below 25 nanomoles SLAL, insufficiency as 25 to 50 nanomoles SLAL, and adequacy as above 50 nanomoles SLAL. In the United States, the equivalent thresholds in ng/ml are roughly 10, 20, and 20 respectively. The problem is that these thresholds were established primarily based on the level of vitamin D required to prevent rickets and osteomalacia, the severe bone diseases caused by Frank deficiency. They were not established based on the level required for optimal immune function, muscle performance, cardiovascular health, insulin sensitivity, or neurological well-being. The reference range defines the floor, the level needed to prevent the most extreme consequences. It does not define optimal, and for most of the biological functions vitamin D governs, the floor is nowhere near sufficient. A substantial body of research now suggests that for optimal function across the immune, muscular, cardiovascular, and neurological systems, vitamin D levels should sit between 75 and 150 nanomolar L, or 30 to 60 nanomolar in US units. This is the range consistently associated with the lowest all-cause mortality, the lowest rates of cardiovascular events, the best immune competence, and the lowest risk of falls and fractures in large population studies. Yet, under the standard laboratory reference range, a person with a level of 52 nmol SLATR would be told their vitamin D is adequate, when in fact they are operating at barely 2/3 of the lower boundary of the functionally optimal range. The second layer of the problem is prevalence. This deficiency is not rare. Research published in the European Journal of Clinical Nutrition has estimated that over 40% of European adults have vitamin D levels below 50 nanomole SLAL, with rates rising steeply in adults over 60, in individuals with darker skin pigmentation, and in those who spend most of their time indoors. In the UK, where cloud cover, latitude, and a culture of covered clothing limit ultraviolet B exposure for the majority of the year, surveys have found deficiency rates of up to 60% in winter months. In Australia, where the sun intensity is far greater but sun avoidance behaviours are widely practiced due to skin cancer concerns, significant deficiency rates exist even in a population living in one of the sunniest countries on Earth. The third layer is the modern lifestyle problem. The human body's vitamin D synthesis system was calibrated for a life spent primarily outdoors in equatorial or near equatorial sunlight. The shift to indoor work, indoor leisure, sun protective clothing, high-factor sunscreen application, and urban environments where buildings shade much of the available sky has dramatically reduced the ultraviolet B exposure that drives vitamin D synthesis. A person working in an office in Manchester or Melbourne applying SPF 50 sunscreen when they do go outside and spending evenings indoors is receiving a tiny fraction of the ultraviolet B exposure their biology was designed to operate on. This is not a personal failure. The architecture of modern life was not designed with vitamin D synthesis in mind. The buildings we work in, the commutes we make, the sun protection advice we are given, all of it has been constructed entirely independently of the biological requirement for ultraviolet B exposure. And nobody has formally connected the dots for the majority of people living inside this system. There are several patterns in which this deficiency shows up in ways that are consistently overlooked. The most common is the cluster of non-specific symptoms: persistent fatigue, generalized muscle aching, low mood, difficulty concentrating, frequent infections that are individually attributed to stress, aging, or overwork, but collectively represent a textbook presentation of chronic vitamin D insufficiency. Because no single symptom is dramatic enough to trigger a blood test, and because the blood test, when it is ordered, uses thresholds that categorize many insufficiency range results as normal, The deficiency continues unaddressed for years. The second pattern is the patient already diagnosed with a condition that vitamin D deficiency is known to drive or worsen: osteoporosis, type 2 diabetes, hypertension, depression, autoimmune disease, who receives treatment targeting the condition itself but never has the underlying vitamin D status systematically addressed as part of management. The deficiency and the condition coexist in the notes, but the causal relationship between them is never joined up. The third pattern is the patient who has been told to take a vitamin D supplement by their GP, has been prescribed 400 IU per day, the standard low-dose recommendation in many guidelines, after 6 months of faithful supplementation, still has a blood level well below the functionally optimal range because 400 IU is demonstrably insufficient to correct deficiency in most adults. They believe they have addressed the problem. They have not. The dose was too low, the monitoring was not done, and the deficiency continued as before. Vitamin D insufficiency does not persist because people are negligent about their health. It persists because the systems designed to detect and correct it are set to the wrong threshold. So what actually corrects vitamin D deficiency? And what does adequate correction look like? I want to frame this carefully because the supplementation landscape is genuinely confusing. There are wildly varying doses available, conflicting guidance, and a real risk of both undertreatment and, in rare cases, overtreatment. The goal is not simply to take more vitamin D. The goal is to reach and sustain a blood level within the functionally optimal range, 75 to 150 nanomole SLEL or 30 to 60 nanomole, and to verify that through testing. The first step is to get your actual level measured and to know what you are looking at when you receive the result. If you are in the UK, ask your GP specifically for a 25-hydroxyvitamin D blood test. It is not always included in a standard annual panel. If your level comes back as normal or adequate, ask for the actual number. A result of 52 nanomole SLEL is technically within the reference range, but is functionally insufficient by the standards of the research evidence. You need the number, not just the adjective. If you are in Australia, the US, or Canada, the same principle applies. Request the specific value and assess it against the 75 to 150 nanomole target range rather than simply accepting the laboratory's pass or fail categorization. The second step is sun exposure, the mechanism the body was designed to use. For adults in the UK and Northern Europe, meaningful vitamin D synthesis from sunlight is only possible between approximately April and September, when the ultraviolet B index is sufficient. During these months, exposing the arms and legs without sunscreen for 10 to 20 minutes around midday produces a meaningful synthesis response. The critical point is that this is skin type dependent. Individuals with darker skin pigmentation require significantly longer exposure to achieve the same synthesis output, because melanin, the pigment that gives skin its color, absorbs ultraviolet B radiation and reduces the rate of vitamin D precursor conversion. For adults with darker skin living at northern latitudes, supplementation is not optional. It is biologically necessary. The sun simply does not deliver sufficient ultraviolet B at those latitudes for melanin-rich skin to synthesize adequate vitamin D for most of the year. The sun exposure that the human body requires for vitamin D synthesis is not the same as the sun exposure that causes skin cancer. They operate through different ultraviolet wavelengths at different times and durations. The two risks can and should be managed independently. The third step is supplementation at an appropriate dose. The standard low-dose recommendation of 400 IU per day is sufficient for preventing infantile rickets, which is the context for which it was established. For correcting deficiency in adults, particularly adults over 50, in whom skin vitamin D synthesis is already reduced by 30 to 50% compared to younger adults, research consistently supports a maintenance dose of 2,000 to 4,000 IU per day of vitamin D3, which is the form most biochemically similar to the cholecalciferol the skin produces. Research published in the American Journal of Clinical Nutrition has demonstrated that a daily dose of 2,000 IU raises vitamin D levels in deficient adults to the functionally adequate range within 2 to 3 months in the majority of cases, with no adverse effects. Doses in this range are widely recognized as safe for long-term maintenance. Very high doses, above 10,000 IU per day sustained over months, can cause toxicity through calcium dysregulation, which is why blood level monitoring matters. But for the vast majority of people, the clinical risk sits at the undertreatment end, not the overtreatment end. The fourth consideration is cofactors. Vitamin D does not work in isolation. Its conversion to the active form and its effects on calcium metabolism are significantly influenced by magnesium, which is a required cofactor for every enzymatic step in the vitamin D activation pathway. Research has shown that up to 50% of adults are magnesium insufficient, and that supplementing vitamin D without adequate magnesium can produce a blunted response. The blood level may rise modestly, but the biological effect is attenuated. Vitamin K2 is a second important cofactor. It directs calcium to the bones and teeth rather than arterial walls, which is relevant when vitamin D is raising calcium absorption. Neither of these cofactors needs to be supplemented in pharmacological amounts. Magnesium-rich foods, dark leafy greens, nuts, seeds, legumes, and dietary sources of vitamin K2, fermented foods, hard cheeses, egg yolks are generally sufficient alongside sensible vitamin D supplementation. I want to be clear, if you are currently taking any medication that affects calcium metabolism, including bisphosphonates for osteoporosis, thiazide diuretics, or any form of calcium supplementation, please discuss vitamin D optimization with your own doctor before making changes. There are interactions that need clinical oversight. The guidance I am providing is for informational purposes and is not a substitute for personalized medical advice, but it is, I believe, information you are entitled to have so that you can have a better informed conversation with your clinician. Let me bring this back to what I observe in clinical practice, because the abstract research only becomes fully real when you see it in actual patients. The presentation I encounter most frequently is an adult in their late 50s who has been living with a constellation of symptoms: fatigue, aching, low mood, recurrent winter respiratory infections, for so long that they have normalized it. They have stopped mentioning it to their GP because they have been told repeatedly that their bloods are fine. When we do measure their vitamin D level properly, with appropriate context around the reference range, it is not fine. It is sitting at 40 or 45 namiolil, technically within the laboratory's sufficient band, but well below the level at which the immune system, the muscles, and the cardiovascular system are operating at their intended capacity. What is remarkable is the pace of change when these patients are properly repleted, brought up to genuinely optimal levels through adequate supplementation. The fatigue begins to lift within 6 to 8 weeks. The recurrent infections become less frequent over the following winter. The generalized muscle aching, which has often been attributed to fibromyalgia or simply to aging, reduces substantially. These are not dramatic overnight transformations. They are steady improvements that over 3 to 6 months add up to a quality of life that the patient had forgotten was possible. I have had patients describe it as feeling like themselves again after years of not quite feeling right. That response, repeated across many patients, is telling us something important. Vitamin D insufficiency matters not just for the specific symptoms it produces, but because of what it represents at a systemic level. The human body evolved over hundreds of thousands of years in an environment of consistent, substantial ultraviolet B exposure. The hormone system built around vitamin D was calibrated for that environment. Every aspect of human biology that vitamin D governs, immune competence, bone density, muscle function, cardiovascular regulation, metabolic health, neurological function, was designed to operate within the vitamin D levels that outdoor equatorial life reliably produced. We have removed that environmental input almost entirely within a single century without replacing it and without systematically measuring the consequences. What the research increasingly suggests is that the cluster of chronic diseases that dominate adult ill health in the developed world, osteoporosis, type 2 diabetes, hypertension, cardiovascular disease, depression, autoimmune conditions, certain cancers, are not simply the inevitable cost of longer lives. They are in part the biological consequences of operating a hormone system designed for high sunlight conditions in a world of offices, sunscreen, and urban shade. This does not mean vitamin D is a cure for any of these conditions, but it does mean that sustaining a chronically insufficient level of a hormone that governs over 200 genes is a meaningful upstream contributor to a wide range of downstream disease processes. Correcting it is not a magic intervention. It is, however, restoring a fundamental biological input that modern life has quietly removed. There is something remarkable about the fact that one of the most consequential micronutrient deficiencies in the adult population is caused not by poverty, not by food scarcity, and not by any failure on the part of individuals, but by the structure of the environment in which most people in the developed world now spend their lives. The correction is neither expensive nor complicated, but it requires knowing that the problem exists, knowing how to measure it properly, and knowing what adequate correction actually looks like. That is what most people have never been told. So let us bring this full circle. If you have been living with persistent fatigue, aching muscles, a low mood that will not quite lift, or a sense that your immune system is not performing as it should, and you have been told your blood tests are normal, there is a meaningful possibility that a vitamin D level measured against an inadequate reference range is part of the picture. That is not a reflection of how carefully you have looked after yourself. It is a reflection of a testing system calibrated to prevent the worst-case consequences rather than to identify optimal function operating in a population whose biology was not designed for the indoor sun-protected life that modern society has made the default. The path forward is straightforward. Get the actual number from your blood test, not just the categorization. Assess it against the functionally optimal range of 75 to 150 nanomole. If it falls short, consider sensible supplementation at 2,000 to 4,000 IU of vitamin D3 per day, alongside attention to magnesium and vitamin K2. Retest in 3 months. And recognize that the improvements that follow in energy, in immune resilience, in muscle function, in mood, are not a placebo response. They are the body returning to the operating conditions it was built for. If you found this video useful, please do subscribe to the channel and help this information reach as many people as possible.